Let's go to page 62. Page 62. Okay, yesterday we started with the kinetics of the gas anesthetics, and the little learning mechanism was to use Dr. Eger's teaching model, which is on page 62. He breaks it into 4 concepts, starting with the machine, and I'm not going to go through that again. Then to the lungs, which are very important. Then the various factors, lung factors, then next the blood, and then finally some tissue factors, which we're going to go through today. So yesterday we went through the number 1, next to the lung factors, and that was ventilation, and that was simple. The faster you breathe, the faster you go to sleep. We went through number 2, which is also simple. The more you give, the faster you go to sleep. So the higher the concentration you turn up on the dials of the gas, the faster it'll go to lung concentration. And then we left off with number 3. Finished the class with number 3. And number 3 is the blood gas solubility coefficient. And what that is it's a measured parameter, laboratory parameter, which is an indicator of how fast an anesthetic is. So in other words, each anesthetic, sevoflurane, desflurane, isoflurane, whatever, ether, they all have an inherent speed. They're going to go in a certain speed. And what determines how fast they are is their chemical structure and how soluble they are in blood. And they're all different. So they're just going to go in at an inherent speed. And that speed is determined or measured by looking at the blood gas solubility coefficient. And the concept being that the drug will be picked up by the cardiac output as the blood passes through the lungs, picks up gas and carries it out to the body. And when it picks up gas, including anesthetic gases and oxygen and so on, when it picks up the anesthetic gases have differing solubilities in the blood. Some want to go in the blood and stay there more than others. And the ones that soak into the blood more don't leave the blood when the blood takes them to the tissues. Therefore, they're slower, making the patient go to sleep. So the higher the blood gas solubility coefficient, the slower the anesthetic is inherently. Now again, we mess with this a little bit, as I mentioned yesterday. We can take, isoflurane, and even though it's the slowest one of the modern anesthetics we use, well, you can bag the patient down, ventilate faster, you can turn the concentration. So we got a bunch of tricks we can try to make it inherently faster than it would be. But nonetheless, they all have a comparable speed. Now, if you look at open drop ether, which we just saw the movies, of that British guy, the anesthetist, as he called himself, giving anesthesia, blood gas solubility coefficient in most books for ether is about 14. So you look at the comparison between desflurane, our current fastest anesthetic, which is 0.42, and ether, which is 14. So in other words, for every 15 molecules of ether you delivered to the he dropped on the face and got the patient to breathe in. For every 15 molecules, 14 stayed in the blood and never left. And 1 went in the brain and put the patient to sleep. So that took a lot of ether. And then he mentions in the movie, it took him 10 minutes just to get through stage 1. So to get into stage 3, you take at least 20, 25, sometimes 30 minutes. Which is, that we couldn't do anesthesia. We wouldn't have surgery today. We had to do that. Oh my God. We have to wait 10 seconds and we're already looking at the clock and I got lunch. I'm going to lunch. So anyway. So that's the blood gas solubility. The lower the number, the faster the anesthetic, and they're in the table there, and we're going to go through it many, many times. But they're listed at a table on page 66, and we'll come back to them a little bit later. So then, starting today then, we'll start with number 4, on page 62. The fourth parameter that Dr. Eger says to consider, and that is ventilation perfusion deficits. So, what it means is this. All right, we're not using the term as strictly as a respiratory person would. In pharmacology, when they say, or Dr. Eger talks about a ventilation perfusion deficit, he just means less than normal lungs, for whatever reason. Now remember, we're delivering these drugs through your lungs. So somebody who doesn't have normal lungs, it's going to affect the delivery of the drug through them, right? Just common sense. You could have, black lung disease from working in the mines in Pennsylvania, and you can have emphysema. We have patients come to surgery with pneumonia that need emergency surgery, so they obviously have less than normal lung function. You can have a patient who's had a lobectomy or even a pneumonectomy to come to surgery. What do you do when a patient only has one lung? Are they going to go to sleep more quickly, more slowly, etc.? So when he, in his thing, says VQ differences or changes, he's just using the ventilation perfusion terminology to mean the lungs aren't normal for whatever reason. And so what happens if the lungs aren't normal? Well, let's turn to page 74 and we'll answer that question. Page 74. I'll go on the camera and point. Now, here's what happens. It's a two-pronged answer to this, okay? So the first, A and B. A is, if somebody has less than normal lungs, they're going to go to sleep more slowly. Right? That's not rocket science, is it? So if they have pneumonia when they come in to surgery, if they have a lung disease of some kind, an emphysema, COPD, if they had lobectomy, pneumonectomy, physically have less lung surface, they're going to go to sleep more slowly. All right? But there's a B part to it. And the B part, and I wrote it for you on the bottom of the page. The B part is this. It affects faster anesthetics more than it affects the slower anesthetics. So I'll say it again. There's a two-pronged answer to this. How does a decrease in lung function affect the speed of anesthesia? Your ability to put somebody to sleep who has less than normal lungs. You're going to see this all the time. You're going to have people with bad lungs come to surgery. What does that mean to you as far as putting them to sleep? Well, the part A is they're going to go to sleep more slowly, and part B is the more rapid anesthetics are going to be affected more than the slower anesthetics. All right? So that's the punchline. That's the end of the story. But let's go back and figure out why. All right, to figure out why is this. People use this analogy. If you're a fast anesthetic, what's a fast anesthetic? It means it has a low blood DES, exactly. It has a low blood gas coefficient. So DES and nitrous are both pretty fast anesthetics, right? If you're a fast anesthetic, let's say this is the analogy that people use. I don't know if it's any good, but I'll try it. Say you're driving a sports car. You're going 100 miles an hour down the LA freeway. Couldn't do it because there's too much traffic. But let's say it's 2 o'clock in the morning, so maybe you are. So you're driving 100 miles an hour down the freeway, and if you all of a sudden can't go 100 miles an hour, you can only go 60, well, that's a big difference between 100 and 60. You're going to notice a big difference in the speed. If you're going slow, 30 miles an hour, and now you're only going 25 miles an hour, you're not going to feel the difference as much because it's already slow. See what I'm trying to say? So the faster anesthetics are going to be affected or noticeably slower than the slower anesthetics, because the slower anesthetics are slow anyway, so it's not going to notice as much difference. Now let's look at my figure. This is page 74. Now these are three anesthetics we don't use anymore, but this is the newest figure I could find. So this is percent deviation from control we're plotting. So 0, that means the normal. This is the control. This is how fast you should be going to sleep. And this is percent deviation. And this is time in minutes. So that's what we're plotting. Now, methoxyfluorine or penthrine, I put the blood gas coefficients here. Penthrine's blood gas coefficient is 14. Halothane is 2.3, and cyclopropane is 0.5. So what they're showing you is slow, medium, fast. 3 drugs. Methoxyfluorine or penthrine being fast. Halothane is intermediate, it's kind of medium speed, and cyclopropane is very rapid. Was a very rapid onset anesthetic because of the blood gas coefficient. So, here you are. How much is a ventilation perfusion abnormality going to affect the slow anesthetic penthrine? Here's normal, and you'll see that it stays pretty much around normal with standard deviation in there. Didn't notice much difference. The medium drug, yes, you got a decrease. Let's say within 10 minutes you were down about 10%. A little bit slower. But with the fast anesthetic, look at, you're way down. There's a 30% difference to start out with, and after 20 minutes it only got it up to maybe 15%. So it stayed noticeably slow. So here's the punchline. Ventilation perfusion deficits slow down all anesthetics, but they slow down the fast ones more than the slow ones. I'll say it a different way. Ventilation perfusion deficits slow anesthesia. The more insoluble the drug, the lower the blood gas solubility, the more it's affected. The higher the solubility, the less insoluble, the more soluble, say whatever you want, half empty, half full, the less it's affected. Okay? Everybody buy that? Very easy. Okay, the next, Dr. Eagles wrote 4 boxes on page 62. The next thing he talks about, ventilation perfusion. The next thing is the second gas effect. So that's the next parameter, so let's talk second gas effect. And the second gas effect is on page 75. Let me explain this. Now, this one's pretty simple. And this is the place I mentioned yesterday where we kind of violate Dalton's law of partial pressures. Because supposedly, according to gas laws, physics, the anesthetics gases are supposed to not mess with each other in the lungs. They have to behave like they're there separately. But this is an exception to that. So what it means is this. When you give 2 anesthetics at the same time, one has to be very, very insoluble or fast. And it has to be given in very high concentrations. Right? So, let me think. I'm stretching my brain. It's Friday morning. Which one of the anesthetics we give is fast and we give a lot of it in high concentrations? Nitrous oxide. Thank you. So, when you give nitrous oxide along with another slower gas, they're all pretty much slower except desflurane. So if you give nitrous oxide in SIVO or nitrous oxide in ISO, then what happens is the nitrous oxide goes into the body so quickly it's drawn into the lungs and into the blood, etc. The uptake is so fast that it draws the other gas in along with it faster than it normally would go in. So if I give, let's say I give somebody SIVO. You're going to do this every day when you go in the OR. That's what everybody uses all the time. So let's say you're going to turn on 3% SIVO, knock somebody out. And you know, I don't know if I said this yesterday, I just thought of something. When I'm talking about giving for the uptakes of these drugs, this isn't especially a mass induction in kids. These are like in adults. I mean, basically, anesthesia, you already know by now. You go in, you hit somebody with pentothal, sleep dose, and they're going to stay asleep about 6, 7, up to 10 minutes, depending on how much you gave. So I walk in, I take one of you, lay you on a table, you're young and healthy, and I say I'm going to give 2 milligrams per kilo of propofol. All right, so let's say you weigh 70 kilos, classic 70 kilo bulk person, and so that's how much? 140 milligrams of propofol. So let's say I give you 150 milligrams of propofol, straight shot. You're going to go to sleep in a matter of seconds. You'll stay asleep about 10 minutes. And then it'll redistribute away from the brain and you wake up. So you got 10 minutes to get this person to sleep for good, for real. That's basically the way we give anesthesia now. So what do you have to do in those 10 minutes while the propofol's still on board? Well, number one, you got to secure the airway. So you got to intubate, or you got to put an LMA down, or you got to slap a mask on. Whatever it is you're doing to control the patient's airway, you got to do that. And that should only take a couple minutes. Then you got to turn on the gas and start pushing it in, ventilating it in. And you got, 5, 6 minutes to get the gas in. So when the propofol wears off, there's enough gas in there to keep the patient asleep. So that's kind of the same background that we're talking about, right? I was assuming you kind of got that. All right, so what some people will do, let's say I hit them with propofol, I intubate, secure the tube, and now I turn on SIVO, 3%, 4%. And if I gave that SIVO 4% in the beginning with 100% oxygen, it'll go in at a certain speed. If I give it with 50% nitrous, it'll go in faster. Because the nitrous is pulled in so quickly that it pulls in the other gas along with it faster. That's called the second gas effect. All right, let's take a look at page 75. This is looking at, well, let's read what that fellow says. In dogs, administration of 70% nitrous produces a more rapid rise, the FA over the FI, this is the rise in the LVI here, than administration of 10% nitrous. The ratio for 0.5% halothane rises more rapidly when it's given with 70% nitrous than when it's given with 10. So in other words, this is how fast it's going in the lungs. So this is 0.5% halothane and 70% nitrous here. And this is 0.5% halothane and 10% nitrous. See, it's going in more slowly. And if I just did 0.5% halothane with no nitrous, where would the curve be? It'd be down here somewhere. Right? Does that make sense? And here, they're just showing the nitrous going in. What does this prove? From yesterday. This is 10% nitrous. How fast that goes in. This is 70% nitrous.
You increase the concentration.
Yeah, it's a concentration effect, exactly right. The higher the dose you give, the faster it goes in. So this is a proof of the concentration effect. Then this is the second gas effect of the drug. So, let me read what I wrote in the bottom, big letters. There's two necessary components for the second gas effect to occur. One, you have to use a very low solubility, fast agent like nitrous, along with another agent that has a higher solubility. You have to use high concentrations of the fast gas. So the only thing that's going to produce the second gas effect is nitrous oxide. So that's the only thing that's fast enough and will give a high concentration. Now, if you give nitrous and DES, do you get much of a second gas effect? No, tiny. If I give nitrous and isoflurane, because it's a lot slower, I get more of a second gas effect. See what I'm saying? Go to the next page. I think it's on there again. Yeah, this is, so this is 65% nitrous oxide in this curve. I'm on page 76, by the way. The rise in the alveoli, Fi over Fi over time. This is nitrous alone. This is DES in 65% nitrous. This is 5% nitrous. And this is DES in 5% nitrous. So there's a little bit of a difference, even with DES. They're both, but what you're showing is the second gas effect, all right? They mentioned in the little legend here, the Fa to Fi ratio for 4% DES rises more rapidly when it's given with 65% nitrous than when it's given with 5% nitrous. And that's referred to as the second gas effect. The second gas is affected by administrating together. Okay? So that was pretty easy. All right. Now, the last thing, next to the boxes on page 62, under lungs, the last lung factor that Dr. Ager wants to talk about, then we're going to move on to the blood. So number 6, page 62, is nitrous oxide diffusing into closed spaces. So let me tell you the story. You don't have to write it down. I wrote it all down for you. All right? We're going to go to, it's going to be on page 76 and on. Here's the story. When you give high concentrations of nitrous, I guess I didn't say this, or maybe. If you're going to give nitrous oxide to somebody, we give at least 50%. If you're not going to use 50%, then what's the point? It's not even strong enough. So at the minimum, you'll see the people who give nitrous give at least 50%. And then if they want, they go up to 70%. And that's where we always play with, 50, 60, 70%. You can't go any higher than 70 because you got to give 30% oxygen. And why give less than 50? Because then you're not getting any effect from it. And it's just maybe causing you problems. So you're going to give at least 50%. Okay? Now here's what happens. 79% of the air in your body, there's air in your body, is what? Nitrogen, right? And if I give 50% nitrous oxide, then I'm replacing at least 50% of that 79% nitrogen with nitrous. So nitrogen is going away, nitrous oxide is coming in. I'm doing that on purpose. I turned it on. I'm controlling it, all right? Nitrogen has a blood gas solubility of 0.01. Nitrogen gas in air. Nitrous oxide's blood gas coefficient is what? 0.47. So we think of nitrous oxide as extremely insoluble, very fast. But compared to nitrogen itself, it's really slow. Nitrogen is 0.01 versus 0.47. That's a factor of 100 times slower. Now what that plays out in the body is this. And I'll say it this way, it's not, I'm using a little poetic license, but I want you to get a picture in your mind. All right? If I take a certain amount of nitrous oxide gas and fill a balloon, you can do that. And I take a certain amount of nitrogen or air and fill a balloon, the same amount. I have the same amount of nitrous and the same amount of nitrogen, fill 2 balloons. The balloon with nitrous will be bigger. because nitrous takes up more space. It's N2O, nitrogen is N2. Nitrous is more soluble, so more has to soak in to reach the same amount of concentration as nitrogen, which is less soluble. So for those factors, when I replace nitrogen in the body with nitrous oxide, the nitrous oxide occupies a larger volume, space. So it's bigger. 50% nitrogen, 50% nitrous oxide. The 50% nitrous oxide is a bigger volume of gas. Alright? So, if you have a place in your body with a closed airspace, and you replace the nitrogen in that closed airspace with nitrous oxide, it makes the part of your body expand, place in your body expand. All right, so what does that mean to clinically? Well, it means this. Number one, and I got this all listed out, just let me talk first. Let's say you have a pneumothorax. It's not unheard of to see a patient come from ER, you call you up or bring a patient over from ER, was in a car accident, has some chest trauma, his chest hit the steering wheel, got 2 broken legs, I don't know, whatever. And you have to put the patient to sleep. They got a pneumo, a small one. Right, that's a closed airspace in the chest, free air in the chest. You push the patient on the table, turn on 50% nitrous, and 10 minutes later, the patient's vital signs go in the dumper. You wonder what's going on. What happens is, the nitrous oxide makes the pneumothorax bigger. It expands the closed airspace and makes it bigger. So the patient's vital signs, they get mediastinal shift, and their blood pressure goes bad, and they're tachycardic, and the whole 9 yards. How would you fix it? Put in a chest tube, right? Or, another one, it's even easier. Turn off the nitrous. Yeah. That's too obvious. Yeah, put it in a chest tube. Why? Because then it's not a closed space anymore. You can put the nitrous in, and any extra volume is going to go out the chest tube. So then it won't have a problem. All right? Now, let's read what I wrote on page 76 in the bold letters. The primary side, on page 76, I wrote this out. Primary side effects of nitrous are well known and easily avoided. Nitrous oxide expands closed gas spaces due to the difference in solubility. With nitrogen it replaces, and the high concentrations were given. Deleterious effects may occur in the following situations. Pneumothorax. All right, everybody get that? Pneumothorax? Okay, how about a bowel obstruction? Think about this one. You're going to work. I guarantee every single one of you listening to my voice, someday when you're at work, is going to get called for an emergency exploratory lap for a bowel obstruction. It's a very common surgery. So the patient has whatever, maybe they're twisted bowel, or adhesions, or a tumor, cancer, something's going on, and they have a bowel obstruction and they're coming to surgery. So you got a bowel all full of air, and it's got no outlet because it's obstructed. So what happens is when you give nitrous oxide, the belly goes, expands. The surgeon opens up and the guts come flying out, all blown out with a big balloon, because the nitrous oxide is expanding the bowel and the air in there because it's a closed space. So, nitrous oxide is contraindicated in bowel obstructions. Well, that's pretty basic stuff. Anyone in anesthesia knows that, all right? How do you fix that? Well, the surgeon had to open the bowel, right? They're going to have to take the tumor out or do a colostomy, or somehow they're going to do some resection. When they cut a hole in the bowel and open it up, the air comes out and then they're fine. But we don't give nitrous to somebody with a bowel obstruction for that reason, because you're going to expand the belly, make it hard for the surgeon to do surgery. Make sense? Let's look at the next one. Inner ear surgery. Think about this one. If you have surgery inside your ear, and this is a little different because it's all bone. It's a bony area, and it can't expand. Right? The bone's not going to get bigger. So the inner ear is not an expandable space. Nonetheless, the ENT is going to take the eardrum off, go in there, do what they're doing. Surgery is going to be coming to an end, and they got to sew the eardrum back on. And if you're giving nitrous and it's bubbling out of their ears, it's going to put pressure on the eardrum, and it's going to make it hard for that to be sewed back in. Now, most ENTs, everybody knows about this, first of all. And most ENTs don't mind you using nitrous. Maybe at the end of when they're getting ready to close, they'll say, anesthesia, I'm closing now. You turn off the nitrous, and it goes away in 5 minutes. So you can go ahead and close. But it's been a long-standing issue of not using nitrous oxide. So if somebody's having a tympanomastoidectomy or some sort of an inner ear surgery for ENT, then nitrous oxide, most people will not use nitrous. Now, strictly speaking, you can use it in the beginning or while the eardrum's off, because it's bubbling out there, no problem. It's when they close what's an issue. All right? Now, take a look at the top of page 77. Same issue, all right? This is from Dr. Miller's book, and there's a reference there. And this is what he says about the inner ear issue. Because this is what I learned when I went to school. I learned that the nitrous is going to be bubbling out, pushing this way. It's going to be pushing on the eardrum from the inside, and it's going to make it hard for the surgeon to sew it on, because somebody's trying to push it off, and they're trying to sew it on. See what I'm saying? But read what Dr. Miller says. On top of page 77. Nitrous oxide diffuses from blood to air spaces within the body. The amount depends on the concentration of nitrous you're giving and the duration of the anesthetic. As nitrous diffuses into the middle ear cavity, the pressure increases and is relieved only by reabsorption after you discontinue the nitrous at the end of the case, or by eustachian tube opening, allowing gas to escape into the nasal cavity. At the end of surgery, after discontinuation, rapid reabsorption of nitrous can produce a negative middle ear pressure, particularly when there's eustachian tube dysfunction or plugged up nose, resulting in graft displacement. Nitrous oxide can displace grafts by causing the middle ear pressure to be either too high or too low. Now, you can't win one way or the other. Now, when you first have nitrous on, it's pushing the eardrum out. When you turn the nitrous off, it's going out of the body so quickly, it actually has a kind of a negative pressure in there. That's pulling the eardrum in. Well, that's kind of crazy, isn't it? So what did he say? Early types of surgery to repair tympanic membranes involved overlay grafts, in which a high middle ear pressure would displace and lift up the graft. Most ENT surgeons now use underlay grafts, in which increased middle ear pressures can help hold the graft in position. Many anesthesiologists do not use nitrous during ear surgery for these reasons, and instead use air, oxygen, etc. I think that's probably the most common practice. And in ear surgery nowadays, people just don't give nitrous. It's a lot easier. Then if the surgeon messes up, it's their problem. All right, does that make sense? So that's pneumothorax, bowel obstruction, inner ear surgery. Next in my list here on page 76, neurosurgical procedures with air injection. All right, there's some types of neurosurgery, craniotomies, brain surgery, that they do where they'll inject air into the brain during the case, to try to isolate where the tumor ends and where the normal tissue is so they can know where to resect. They may inject air in the ventricles, and then they do ultrasound to try to localize the tumors, all in an attempt to be more precise and only take out the bad stuff and not any good tissue. So it's not unheard of in certain types of craniotomies to inject air in the brain. It's a way to make a contrast, then do an ultrasound and make sure you can see where the tumor is. They do this intraoperatively. Now, if they're doing that, and you're giving nitrous, you're making the air that they put in the brain bigger. That's not good, because you're distorting things. So we don't give nitrous for those procedures. Oh, look at this one. Next one. I'm excited over this. Page 76. Air embolism. Oh, wow. There's many, not many, but some procedures that we do, surgical procedures, where air embolism is very real complication. And basically, it's any time the incisional area is above the heart. It's like you having a patient sitting up with a CVP in, and you disconnect it or something. The air can suck into the IV tubing, right? You know that as nurses. Well, just think if you're doing surgery, say on somebody's back, you're doing a spine surgery, they're lying prone on the table, so their heart is lower than the incision, and the surgeon's cutting, and they got all those venous sinuses in the wound, and they're sucking air in, and the patient ends up with an air embolism. What about a craniotomy? They're doing sitting, or with the head up. Air, scalp's open, brain's open, air sucks into these venous sinuses, goes down into the heart, air embolism, problems. So there's several types of procedures, spinal fusions, Harrington rods, anything where the incisional area is higher than the heart level, where you can suck air in to the incisional area and you can end up with an air embolism. We have special procedures we do. For certain cases, we have special air embolism monitors we put on. We look for air. I mean, it's a very well-known complication. You'll learn about it when you learn neurosurgery, orthopedic surgery, whoever teaches all that. You'll learn about how do you monitor for, and what if they do get an air embolism, what do you do? The surgeon has to immediately pack the wound with wet packs, and you put the patient down, you have a CVP, and you try to suck air. That's a whole big thing. That's not pharmacology, all right? All I care about is the air embolism can happen. So at this point in your training, trust me that there are certain procedures we do where air embolism is a real possible side effect of the surgery. And we, again, monitor and treat very real, in a real sense, that. Well, what do you got an air bubble? You give it nitrous. It makes the air bubble bigger. Let's take a look. This is top of page 78. It's top of page 78. All right. This is an LD50 study. Remember that? LD50? Lethal dose. So what they're looking at, this is an air embolism equaling 0.55 mLs per kilo, and that kills 50% of the rabbits breathing oxygen. So they're purposely injecting air, IV, in these rabbits to see how much it takes to kill them. It's brutal, I know. If the inspired gas mixture contains 75% nitrous, it only takes 0.16 mLs per kilo to reach the LD50 instead of 0.55. So this is volume of air times 10 in mLs per kilo injected in the rabbit, and percent of the animals that died, LD50. 50% here. So if you're giving nitrous, you've only got to give 1 point something ml, and if you're not giving nitrous, you had to give 5 point something mLs. You get the point. Nitrous makes the bubble bigger. So, if the patient has an air embolism, right off the bat you turn off the nitrous as fast as you can. And also, in procedures where air embolism is a possibility, we just won't use nitrous at all. So in certain neurosurgical procedures, in spine surgery, all these kind of things, again, you learn about them as you go through anesthesia 4, the various things. Then we don't give nitrous oxide because nitrous can expand an air embolism issue. All right, see that? All right, going back to 76, air embolism was next. Patients, the old guys getting carotids. A lot of times you're going to do vascular surgery when you go to work for that day, and it'll be a bunch of guys my age having their carotids reamed out or bypassed or whatever. And there's a very real issue of air embolism possible with that. So you wouldn't want to use nitrous in those patients, etc. Now, there's eye procedure next. When the ophthalmologists, occasionally when they do retinal surgery, they will inject sulfur hexafluoride gas. It's called SF6 gas. They inject a gas bubble into your eyeball to try to separate the structures in there so they can differentiate, again, lines of tissue and where they cut and where they shouldn't cut and so on. So certain ophthalmology procedures, when you're doing a general anesthetic, and the surgeon, and you'll know it, and he's going to say it right out loud, he's going to tell you he's doing it again, you're going to see him sticking the stuff in there, so it's not going to be some big mystery. So he's going to inject this patient with this SF6 gas bubble in the eye to help him do the surgery or her do the surgery. Then you can't give nitrous because you're going to make it bigger. You increase intraocular pressure and it could cause problems. So in certain ophthalmologic procedures, if they're going to inject hexafluoride gas, you can't give nitrous oxide. Okay? It's a retinal detachment repair, etc. Now, laparoscopy, putting air in the belly. We do all kinds of, most surgery now with laparoscopic methods. And there's a potential for expansion of air. We use carbon dioxide so there's not as much nitrous displacement. So it's more academic, but you at least have to, you can use nitrous, but you have to kind of be careful. But we're measuring the belly pressure anyway. When you do laparoscopic, you have a little gauge that measures how much pressure's in there. They fill the air belly with gas, stop at a certain pressure, look on the camera. So it's all right in front of you. It's not a problem. Okay, then finally, what about an endotracheal tube? Endotracheal tube has a cuff. The cuff is the airspace that's closed. You intubate somebody, you blow up the cuff with 4 mLs of air, you're happy, you got a nice seal, you're off and running, you do the case, 2 hours later the surgeon's done, and you want to put the cuff down, you pull out 8 or 9 cc's of air. Hey, where'd that come from? I only put 4 mLs in the beginning, I only got 9 mLs at the end. It's nitrous oxide. Nitrous oxide diffuses across the wall of the endotracheal tube into the cuff. It's a closed space and it makes it get bigger. So you have to kind of be careful with that too. Some very anal retentive CRNAs or anesthesiologists, they actually carry a little gauge and they measure the pressure inside the cuff. I've worked with a few. That's really, that's getting into the nitty-gritty. And also they say pulmonary artery catheter, because if you wedge a catheter, you're blowing the little balloon up. You could possibly expand it. So, I mean, that's second thing. We're not doing that during surgery. First of all, we never use PA catheters anymore anyways, except for an open heart. Secondly, you don't usually wedge them. But it's something to at least say in class. All right, so finally, let's wrap this up. Page 79. Page 79. All right, I made this table up, and from data that I got from this reference there, and I put the reference for you. Page 79 on the top. Nitrous oxide induced space or compartment changes. And here they are. Pneumoencephalon, injecting air in the brain. CSF pressure increases to 3 times baseline in 5 minutes if you're using nitrous. Intraocular hexafluoride gas. 2 to 18 millimeters of mercury increase in pressure in 20 minutes if you're using nitrous. That's not good, right? The intraocular pressure goes up 18 points. That's going to be a no-no. Middle air pressure. Increase in 1 to 7 millimeters of mercury in 1 hour. In a pneumothorax, you can make it 2 to 3 times the volume in 5 to 20 minutes. Intestinal gas, for example, bowel obstruction, you can double the size of the intestines in a little over 2 hours. And an air bubble, like an air embolism, immediate increase in size occurs. So this is what the literature shows in all those different situations. Needless to say, they're all contraindications to using nitrous oxide in any of these types of procedures, the situations, because, for the obvious reason.
Are these all at 50% nitrous oxide administration?
50 to 70, yes. Okay, is there anybody have any questions about that? Now, if somebody's having bowel surgery, and I want to say this, I'll give you a break, I promise. Bowel surgery, you can use nitrous oxide. Because just normal bowel surgery without an obstruction, there's an air outlet. Do I have to spell it out? So you're not going to get an increase in pressure. So it's only if there's an obstruction, because then it's a closed air space. See what I'm saying? So you'll see people using nitrous all the time for people who have abdominal surgery just by itself. We're talking specifically about a bowel obstruction. That's when it won't have an outlet and it gets bigger. All right, let's take a break. Okay, let's start up again. Okay, next box in page 62 is blood. So let's talk about blood. You notice the thing, I only have one statement next to that, and that's cardiac output. So let's talk about that. It's an important point. Go to page 79. Page 79. All right, a couple things. Number one. If you look inside the body where the blood's flowing at any given point, Dr. Ager broke this into 4 areas according to blood flow. And what he said is this. Let's say you take that classic 70 kilo person and you stick him on a scale and then you dissect him and you see something like this. And look at the table on the bottom of page 79. If you take all their vital organs out, heart, liver, thyroid, kidneys, brain, and weighed them on that scale, out of the 70 kilo weight that they have, the percent of the body mass would be about 10%. So about 7 kilos weight would add up by weighing the heart, lungs, thyroid, brain, the basic vital organs on a scale. However, perfusion is a percent of cardiac output. See, I'm reading about page 79. They get 75% of the cardiac output. Well, we know it. Most of the blood flow in the body goes to the vital organs. So 75% of the cardiac output goes to 10% of the body weight. And he called that the vessel-rich group. He said, let's call it the vessel-rich group. Now, that's a good thing for us, right? Because we want the drugs to go to the brain. The brain is in there, in the vital organs. It's the most vital organs. And it gets a high amount of cardiac output, so that's a good thing. Second, he said, let's look at muscle. So if you take all the muscles out of somebody's body, weigh them, that's about 50% of their body mass, and it gets around 19% of their cardiac output. All right, number 3 area, he said fat. Let's take the fat out of the patient's body. He said that would be about 20% of the body mass. Now this isn't, this includes cell membranes. I mean, this is all the fat in your body, right? It's not just you go to the gym and get your fat measured or something. 20% of body mass, but it gets 6% of the cardiac output. Fat is not very well perfused. You see it every day when you go to work. They cut through the skin, the sub-Q, and the fat and all that. There's not much bleeding, there's not much vascularity. Fat doesn't have a lot of blood flow. So it's 20% of body mass, and it's only about 6% of the cardiac output. And then finally he said throw everything else in, we'll call it vessel poor. So vessel poor was skin. I'm sorry, not skin. Vessel poor was bones, teeth, hair, skeleton, the rest of your skeleton, cartilage, all these areas. He said, let's just put them all in there. They weigh about 20% of body mass, your skeleton, etc. And we'll just say, for all intents and purposes, they get 0 blood flow. This is drug distribution. I know they get some blood flow, right? Your bones get some blood flow, otherwise you get avascular necrosis and so on. But for all intents and purposes, for drug distribution, it's not going to matter. So let's just say 0. So he broke the body into these 4 compartments. Vessel-rich, vital organs, getting 75% of blood flow. The muscles at 19%, fat at 6%, and then the rest of the body just make it 0. Look at the next page. This is a kind of an artist drawing of this same thing. I'm just repeating myself, all right? There's the vessel-rich group, brain, heart, kidney, liver, etc. 75% of the cardiac output. Muscle group, 50% of your weight, getting 18% of cardiac output. The fat, he says 19%, is getting 5%, and vessel poor is 0. So it's kind of the same idea. So the cardiac output, when when the blood goes through your lungs, and picks up drug and starts carrying it off to places, 75% is going to the vital organs. A vast amount of that is going to your brain, and that's a good thing. It's a lot easier to get a drug in to go towards the brain than it is to go into your left foot or something like that. Right? More blood flow. Okay, now the second thing about cardiac output, and that's this. Well, before we get off that, let's go to page 81. This is a computer simulation showing the partial pressure of an anesthetic in these various areas over time in minutes. And so they're just trying to show if you're turning anesthesia on, saying they're giving an anesthetic, surgery's going on, where is the anesthetic going at any given point? Well, first of all, in the circuit that you're delivering it in, that's going to have the most amount because it's coming out of the machine. That's pretty obvious. And then since we're delivering it through the lungs have the second highest concentration. And look at the brain. See the two curves? Alveolar concentration, brain concentration. And remember yesterday I said we measure the alveolar concentration, that's why we call things MAC, the dose of MAC, but we assume it means the brain concentration, and it does. And here's the proof. Because the curves are always the same. The amount in the lungs is the same as the amount in your brain. Because, in a very short order, number one, the anesthetics are so lipid soluble, the alveolar membrane doesn't offer any barrier, and the blood-brain barrier doesn't offer any barrier. They go wherever they want. Number two, cardiac output to the brain is so high that as soon as you get a lung concentration, it's going to be reflected in the brain very quickly. And that's why these two are the same. All right, how about muscle? Oh, look at that. So let's say an hour into the case, this is how much is in your lungs, this is how much is in your brain, I'll put a little X here, how much is in your muscles? Oh, not very much, not as much, right? A lot less. Why? Because the muscles don't get the blood flow. It's not being distributed into the muscles, in spite of their large volume and mass. And then, of course, here's fat. So, the amount of the fat at any given point is less than the amount in the muscles, and the amount in the muscles is less than the amount in your vital organs. All right, make sense? All right, now we come to cardiac output, number 2 point. And that's this. This happens during the case a lot. During induction, I should say. What happens if I'm putting someone to sleep and the heart rate goes up? I want you to go in the OR when you first go in and start watching and doing, hopefully doing pretty quick, that almost every time you put someone to sleep, they get tachycardia. Propofol makes their heart rate go up. Anesthetics tend to make the heart rate go up, at least initially, to get them into stage 3, deeper. So generally there's an increase in heart rate. If somebody's gets light, if somebody's nervous, if whatever, their heart rate goes up. All right. So, let's say I'm putting someone to sleep. What happens if they have an increase in cardiac output during induction? Tachycardia, whatever. What if their cardiac output goes up during induction? Do they go to sleep more slowly, or do they go to sleep more quickly? Now, I'll tell you the way I answered it when I was where you were, and I was wrong. This is what I thought. Okay, the patient's going to go to sleep at a certain rate. Now you're telling me that I have a little kid there and their heart rate went up 20 beats a minute because I made them nervous during induction, whatever. So they have an increase in cardiac output. They're going to go to sleep more quickly. Because I thought, well, if their blood's circulating faster, it's going to get to the brain faster, and it's going to make you go to sleep faster. And I was wrong. It's the other way around. When you increase your cardiac output during induction, you go to sleep more slowly. Here's why. It seems counterintuitive, but it's true. So let's see why. If your blood pressure and heart rate's at a certain point, and I'm giving you anesthetic, I just start the anesthesia, just turn it on, you've been breathing gas about a minute or so, and your cardiac output goes up, then what happens is, the blood doesn't have much in it already because we just started. Now it goes to the lungs faster. So it draws the anesthetic out faster. The anesthetic gas level in your lungs falls. And the lung concentration is always the same as the brain concentration. So if the anesthetic concentration in your lungs go down, the anesthetic concentration in your brains go down. You go to sleep more slowly. Now, the whole reason this happens is because there's nothing in the blood when we start. So the more blood you put into the lungs, the more it soaks out of the lungs, the lower the alveolar concentration, slower the alveolar concentration is going to rise, the slower the patient's going to go to sleep. If I have a tachycardia happens 30 minutes into the case, nothing happens. The patient's level doesn't change. Because by then, they're already asleep, there's a good blood saturation, and you're not going to see much change. All right? The whole thing happens because of the fact that there's very little in the blood, and now I'm putting more blood through the lungs. So yeah, it's picking up more, but by picking up more, it's making the alveolar concentration go down. Right? Let's take a look at this figure. Page 82. You're not sure you believe me yet, and I don't believe it. I didn't believe it either. All right, here's a simulation. This is the amount FA over FI over time and different cardiac outputs. So they're saying here's a cardiac output of 2.5 liters per minute, 5, 10 for nitrous oxide. This is isoflurane, 2.5, 5, and 10. So they're showing you two different agents. One very rapid, one very slow. Not very slow, but slower. All right, let's start with the slower one. These three lines are isoflurane. So if cardiac output's 2.5 liters per minute, a little bit low, then that's the rate of rise in the lungs. If you have a cardiac output of about 5 liters per minute, that's the rate of rise. And if your cardiac output is 10 liters per minute, you're beating your heart to death, but nonetheless, it's a simulation, and go in more slowly. So increased cardiac output slows the rise in the alveoli. All right? This is nitrous oxide. 2.5 liters per minute, 5 liters per minute, 10 liters per minute. Increased cardiac output slows the rise in the alveoli. But not as much, right? There's not as much difference between these three lines for the nitrous one than it is these three lines for the isoflurane one, right? So, let's read what the folks say. The impact of cardiac output on the alveolar anesthetic concentration. This is another one of those A and B ones. There's two parts to this. During induction, increased cardiac output, pulmonary blood flow, results in a slower rise in the alveolar concentration because uptake from the alveoli into the pulmonary blood is accelerated. The dependence of the alveolar pulmonary concentration rate of rise on cardiac output is greater for highly soluble agents and minimal for insoluble agents. The impact of cardiac output is the same as that. In other words, when they're waking up, it's the same as when they're going to sleep. So, what did I write? Increases in cardiac output slow the onset of all anesthetics. However, they slow the soluble agents more than the insoluble. They slow the ones with the highest blood gas coefficient more than the lowest. Because if the whole reason your alveolar concentration is going up more slowly is because the cardiac output is soaking more anesthetic, then the more soluble the anesthetic, the more soakable the anesthetic, the greater the effect's going to be. If your anesthetic is not soaking much anyways, it doesn't matter how much you change cardiac output, it's not really to change how much soaks in the blood. That's very insoluble anyway. That's why nitrous doesn't show as much effect versus isoflurane, which does. So there's two things going on here. I'm backing it up because I'm going to ask you this on the first test, and you're going to have to know this forever. Ventilation perfusion deficits slow down the uptake, the ability to put someone to sleep with the inhalation anesthetics. I'm backtracking here. The anesthetics. However, it affects the fast ones more than the slow ones. All right? Increases in cardiac output slow the ability, the speed of putting someone to sleep. However, it affects the slow ones more than the fast ones. It's the other way around. So bad lungs affects the fast ones more than the slow ones. And cardiac output increases, affect the slow ones more than the fast ones. Here's another one. Just the same thing, different figure, page 83. Let's take a look. Exactly the same thing. Here's isoflurane. This is the normal uptake. And this is when the cardiac output is doubled. This dashed line, see it goes in more slow. This is DES, a real fast one. This is the normal solid line, is the normal uptake. And if you double the cardiac output, the dashed line is the slower DES uptake. So they're both slowed. However, the isoflurane, the slower one, is affected more than desflurane, the faster one. Question?
So for a patient who's got a bad lung, would you purposefully give them a slower gas?
No. What you would do is probably crank up the concentration higher. So instead of going up to, 4% SIVA, maybe you'd push it up to 6-8%. Just to try to compensate, you'd ventilate them faster. So you mess around with it that way. All right. Let's read what Dr. Miller says on the bottom. Page 83. The effect of altering cardiac output is intuitively obvious. Well, not to me. It was intuitively obviously backwards to me. If more blood passes through the lungs, more blood is available to remove anesthetic. Therefore, the lower the FI ratio. To the student of uptake and distribution, this may appear to produce a conflict. It would seem that if more agent were taken up and delivered more rapidly to the tissues, the anesthetic partial pressure would rise more rapidly. In one sense, this can be true. An increase in cardiac output does hasten the equilibrium of the gases. However, it ignores the fact that the lower FA over FI ratio is going to be more of an effect or effector. The partial pressure in the central nervous system cannot exceed that in blood, thus the lower FA over ratio produces a lower partial pressure in the brain. That's his explanation. Because the anesthetics are working on a driving pressure. And again, I hopefully said this and made it real obvious. But the highest concentration of the anesthetic is in the machine. The next lowest is in the lungs. Next lower is in the blood, and the next lower is in the tissue. As long as that's true, the anesthetic is going to move in. It goes down its concentration grade. Right? At the end of the case, I turn the anesthetic off. I put in 100% oxygen. I got nothing in the machine. Then everything just reverses itself. And it starts going out because it's going down its concentration grade. And that's what he's saying. As long as the concentration in the lungs is higher than the blood and higher than the tissue, then it's going to drive that way. All right? Now, look at page 84. They sum it all up in this cute little diagram. I found some book. I can't remember where. But this is the FA to FI ratio over time. For this is uptake of anesthetics in the lungs. And the middle line is the normal. And they go, what makes it go in faster? All right, there, I'll go and point. All right, there's the normal line. What would make anesthetics go in faster? Well, the lower the solubility of the anesthetic, the faster it goes in. That's it, low blood gas solubility, right? Faster the drug. Number two, low cardiac output. If your cardiac output goes down, it goes in faster. If it goes up, it goes in slower. High fresh gas flows. If you turn the dials on real fast in the beginning, we talked about that, so what? Then finally, high minute ventilation. The faster you breathe, the faster you go to sleep. Those are all factors that are going to make you go to sleep faster. Now follow the little arrow down. Here, what's going to make you go to sleep, rise in the alveoli, be slower? Well, if it's a high solubility drug, that means blood gas coefficient's high, isoflurane, for example, that's going to go to sleep more slower. High cardiac output, increases in cardiac output decrease the speed of induction. Low fresh gas flows and low minute ventilation. It's kind of self-explanatory. All right? Make sense? Okay, that's it for the blood. Now let's go to finally to the last box. Page 62. And the last box is this. He says a couple factors as far as once the drug is delivered to the tissues, then what about, and there's his factors. Oil gas solubility, metabolism, and diffusion hypoxia. So let's start with the oil gas solubility. And this one's real easy. Let's go to page 66. Page 66. And the table on page 66 on the bottom, the last column is called, or is the oil gas solubility coefficient for the different anesthetics. Now, yeah, page 66, bottom table, right-hand column. You see there's another partition coefficient called the oil gas partition coefficient. So let me talk about this. And actually, it's interesting. There was a couple of scientists back in the 1900s, I think the early 20th century maybe, Meyer and Overton. And they were studying anesthetics in goldfish, in fact, and other animals, and they noticed something, which at the time was pretty revolutionary. Now it's kind of like, so what? But they noticed that the more lipid soluble the drug was, the better anesthetic was, more anesthetic properties it had. So they came up with what they called the lipid theory of narcosis, and it lasted for several decades, and said that the anesthetics are directly proportional to their lipid solubility. Right. That's what produces anesthesia. Well, it's still true, and we still agree. We agree with that. Definitely the lipid solubility matters, but what doesn't explain how anesthetics work. What explains is their potency. The more lipid soluble they are, the more potent they are. So Meyer and Overton's theory is still true. It just doesn't explain how the mechanism of anesthesia. What it explains is the potency of the anesthetics. So back in the 40s and 50s, when they were really doing a lot of studies with anesthetics, they used to, they came up with this parameter, partition coefficient, just like blood gas. They called it oil gas because what they would do is they bubble the anesthetics in olive oil. And because they felt that olive oil had a constituency similar to cell membranes, the lipid properties that were kind of like cell membranes were. Then, back in the 70s and 80s, when they actually devised or grew artificial cell membranes, and they could test them in real cell membranes, they found out it was almost exactly as olive oil. So they just kept doing it in olive oil. They figured, what the heck? Why change? So, to this day, they stick with what's called an oil gas partition coefficient. Now again, these are ratios, partitioning in one phase versus another. So these are all over 1. What they mean is this. So let's start with sevoflurane. The oil gas partition coefficient for sevoflurane is 50, or it means 50 to 1. So what it's saying is, when I get this sevoflurane, finally I get it up in the brain, and it's right where it needs to be, 50 molecules of sevoflurane will knock the patient out for every one that doesn't. That's its potency. Isoflurane, 99. It means for every 100 molecules of isoflurane I put in the patient's brain, 99 are going to knock the patient out, 1 isn't. Make sense? So, the higher the number, let me summarize. The oil gas solubility coefficient of an anesthetic is the parameter that tells you the potency. The higher the number, the more potent the anesthetic. Which is the most potent anesthetic on this table? Halothane, right? What's the next most potent? Now, the real ones we still use. What's isoflurane? What's next? Sevoflurane, right? What's next? DES. What's the least potent anesthetic? Nitrous oxide. 1.4. So, let me backtrack and summarize again. The blood gas solubility coefficient of an anesthetic tells you the speed, induction and emergence. The oil gas solubility of an anesthetic tells you the potency, how well it works once it gets there. You can have a drug that's fast and not very potent, like nitrous. You can have a drug that's slow but extremely potent, like penthrane used to be. I think the blood gas, or the oil gas coefficient of penthrane was 700 or something like that. So it was real slow to get in, but it didn't take much because it was so potent. So there are two different properties. The different properties for speed and potency. And you got to separate those two in your brain. As far as how fast you can get them in and out, and how well they're going to work when they're in there. Okay, let me take it to one last thing now. I'll talk science. Level of talk science. Then I'll say it in plain English. The oil gas solubility coefficient is inversely proportional to the MAC. Or the other way around, the MAC, an anesthetic, is inversely proportional to the oil gas coefficient of the drug. In other words, the more potent it is, the less you have to give. That's what I'm saying. So the higher the oil gas, the lower the dose, the lower the MAC. Look at the MACs on these tables. The oil gas coefficient of halothane is 224, and the MAC is 0.75. So it's potent, so you don't have, the dose is lower, see? They're inversely proportional. Look at nitrous oxide. The potency is only 1.4, and the MAC is higher than, you can possibly give. You can't reach the MAC in the real world. So the oil gas coefficient and the MAC, the dose, are inversely proportional. One's high, one's low, etc. Look at DES. 18.7 oil, 5.8 MAC. So it's kind of in the middle. Make sense? Okay. The next thing on the boxes on page 62 is metabolism. So I'm just going to blast through this pretty quickly because we're going to talk about it in great detail next week. But let me say for now, because this is pharmacokinetics. That's absorption, distribution, which we've talked about, metabolism, and elimination. So the metabolism part is, and I'll just tell you this, and I probably have it in here somewhere. I'm sure I do. I'll find it for you. But here's the story. The metabolism of anesthetics, and we're going to cover this in great detail. When anesthetics have been metabolized historically, they've produced toxic metabolites, and they were very often lethal. You'll learn about penthrane. Back in the 60s, it was metabolized, and it caused renal failure and death. Halothane is world famous for causing liver necrosis. That's one of the reasons why we stopped using it. The term they used for it was halothane hepatitis. It wasn't hepatitis, but the patient looked like they caught hepatitis because they turned jaundice and they got fever and then they ended up dying. It was from the metabolite of halothane. We went through a whole big thing about that and so on. So the metabolism of the anesthetics has always been kind of a problem because a lot of the metabolites that were produced were toxic. So there was a great push in the last 30, 40 years to develop anesthetics that were inert, that were not metabolized in the body. And we've been largely successful. Isoflurane, when it came out in the early 70s, late 60s, was the first anesthetic, major anesthetic, and it was metabolized less than 1%. We had no toxicity. We were safe. We finally got rid of all that problems with the livers and the kidneys and liver failure. Everybody's happy. Then Desflurane came out, and it is metabolized, and I'm going to show you this in great detail, how it's metabolized, what it's metabolized, and so on. But it's metabolized less than 0.1%. So Des is even safer. So we were just thrilled. We got enough issues to deal with in surgery without having to worry about people, dying 2 days later of liver failure or something like that. It was a problem. So we had solved the issue of drug metabolism, anesthetic metabolism, producing toxicity from about the early 70s all the way through the introduction of sevoflurane. And when Sevo came out in the late 1990s, early 2000s, Sevo is metabolized about 5 to 7%. And it's a toxic metabolite. We thought, oh no, now we got to go back to all that nonsense, right? But it's safe, and I'll tell you why and so on. But nonetheless, of all the anesthetics, so nitrous oxide is not metabolized, it's inert. Des and isoflurane are both metabolized less than 1%. I'm going to show you this later on. And Sevo is the only drug that still has any degree of metabolism. It's about 5 to 7%. Some books will say 6 to 8%. I don't know, whatever. You sure it isn't 8, not 7? It's awful precise. So the anesthetic metabolism is something we're going to cover next week. Okay, so we'll leave it at that. And then finally, the last thing next to the box there from Dr. Egger is diffusion hypoxia. So I want to talk to you about that, and in order to do that, we're going to turn to page something. I'll find it. Right here, page 87. All right, let me just tell you about this. It's pretty simple. Diffusion hypoxia is kind of the opposite, or of what second gas effect is. So what happens with the diffusion hypoxia is this. At the end of the case, when you wake the patient up, let's say you're giving 50% nitrous, 70% nitrous. You're either doing one or the other. Let's pretend it's 70. So let's say the case is over, the surgeon put the dressing on, everybody's happy. We got to hurry up and get in the PACU. So you take the mask off the patient. They were getting 70-30 nitrous oxygen. Take the mask off, set it in a machine. bounce on out to recovery room. What happens is this. Because nitrous oxide leaves the body so quickly, because it's so insoluble, in the first 3 to 5 minutes, it's going to go all the way out of the tissues, through the lungs, out into the environment, blow it out. And as it passes through the lungs, so much of it goes through so fast that it can dilute the gases that are in the lungs. So let's say I'm breathing room air, 21% oxygen, and all this nitrous starts pouring out of my tissues and my blood, tissues into the blood, blood into the lungs, lungs into the environment, right? And as it passes through the lungs, this big amount of nitrous all at once, it can dilute the 21% oxygen that's in there and make it maybe go down to 18 or 17 or something like that. We call it diffusion hypoxia, all right? The patient can get hypoxic, even though they're normal, breathing normal, looking normal, and acting normal, just because of this rapid diffusion of nitrous oxide out of the body, through the lungs, off into the, well, in our anesthesia machines, it's a closed system, so we scavenge the gas out, put it on the street. That's diffusion hypoxia. It occurs because of, number one, it only occurs with nitrous oxide, because it's the only one to give in large amounts. And it's fast enough to do it. So let's take a look at page 87. This is the PaO2 here, minutes after the end of nitrous, 0, 5, and 10 minutes. And this is the nitrous oxide output. So what they're showing is at time 0, you turned the dials off, you took the mask off the face. Nitrous, so the next 2-3 minutes, look at this. The amount coming through the lungs just goes sky high. It's all pouring out of the body. Tissues, blood, lungs, environment. So your O2 in the lungs goes from 70 to down to, ooh, that's not good. Down to hypoxia, see? When? Between the first 5 minutes of after you turn the stuff off. The end of the case, first 5 minutes or so. Then when the nitrous goes away, the O2 comes back up. Let's read what they said. At time 0, the inspired gas was changed from 21% oxygen, 79% nitrous, to 21% oxygen, 79% nitrogen. So in other words, they just had to breathe air. Arterial oxygen subsequently fell in association with the outpouring of nitrous oxide. This is diffusion hypoxia. So how do we prevent this from happening? We do this in every case. Every case. Give 100% oxygen at the end of the case. Exactly. You never turn nitrous oxide off, take the mask off, disconnect the endotracheal tube, disconnect the LMA, whatever airway device you're using. You always turn the nitrous off, turn on 100% oxygen, and wait 5 minutes. Let them blow the nitrous out. And during that 5 minutes, if you're given 100% oxygen, you've pushed the patient's lung concentration up to, 300 PaO2, and now it dilutes down to 200, who cares? It's still twice as high as it has to be, right? They're not hypoxic. So, what this comes down to, and I'll finish this for the day, we begin every operation with 100% oxygen, because our other dials won't turn on, as Jeremy showed you in the movie yesterday, unless you start with oxygen. We start every case. We always do it, anywhere you go in the world, 100% oxygen. And we finish every case with 100% oxygen, no exceptions. Now, even if we're not using nitrous oxide, oxygen's like mom and apple pie. We're so used to finishing with 100% oxygen, we just turn on 100% oxygen, even if I didn't give nitrous. So I don't really have to, but it's nice to push the PO2 up. So the little trip to the recovery room, they're not going to drop. So you don't hit the PACU, the nurse puts on the clip on their thumb, and their saturation's 80, and they're looking at you like, what's up? So it's always nice to have a little oxygen in there. So we always finish all the cases with 100% oxygen. There is no oxygen toxicity in anesthesia. You can forget all that nonsense. It doesn't happen. Our cases aren't long enough. We don't do it the way you need to. We don't have any problem. We give oxygen like we crazy. It's the best thing. If ever you see a test, somebody gives you a test in anesthesia, and one of the answers is give oxygen, circle it. It's going to be correct. I promise you. See you next week.